Okay, we're going to go ahead and get started just in the interest of time. I know we're not in our typical auditorium, but thanks everybody for finding your way. I always end up getting lost when I try to find this auditorium, but welcome to all of you and to all of you on Zoom. For those of you who do not know me, my name is Renee Madathel. I'm a neuropsychologist in the Department of Psychiatry and Surgery. I spend my clinical time over on the burn team, many of whom are here. Hello. And today I have the great pleasure to introduce Dr. Shelley Wiechman. Dr. Wiechman is a professor in the Department of Rehabilitation Medicine at the University of Washington Medical Center, where she also serves as the Director of Psychological Services for the Regional Burn Center at Harborview Trauma Center. Her clinical expertise spans psychological adaptation to injury and disability across the continuum of care, and her research focuses on non-pharmacologic treatments for pain, itch, long-term adjustment following burn injury, coping, and resiliency. Among her many honors, Dr. Wiechman was recently awarded the Lifetime Practice Award from the Division 22 of the American Psychological Association in recognition of her transformative contributions to the field of rehabilitation psychology. She also received the Curtis P. Arts Distinguished Service Award from the American Burn Association for her service, including her leadership in establishing clinical practice guidelines and advancing mental health support for burn survivors. I will say she is also the recipient of several teaching and mentorship awards, which I can personally say are well-deserved, as she was my mentor during my residency program. So please join me in welcoming Dr. Shelley Wiechman.
Thanks, Renee. That was sweet. Wow, thank you, Renee, and thank you for the invitation to be here. It's been great. Gotta say, Dr. Madathel was one of my favorite residents, and there's no greater joy professionally than to see your residents surpass you and build these great programs wherever they go, and that's certainly been the case. I've really enjoyed meeting those of you this week that I've gotten the pleasure to meet, and I look forward to meeting more of you. I'm going to talk today about different theoretical models of burn recovery, just as a way of kind of describing where burn research started and where we are now, and where we should go. And I like doing it just according to the different theoretical models as we use that to drive our research questions. Dr. Madathel already described my roles right now. I am in the inpatient burn unit, which for us includes the ICU and the acute care, and then I also float to our burn and plastic surgery clinic. I also have a portion of time focused on faculty well-being and retention. And then she described my research areas are on pain and long-term outcomes following burn injuries. So, I did that one. I wanted to just go over really quickly, most of you know this, but wanted to just talk a little bit about the incidence of burn injuries, and especially as compared to TBI and SCI. Coming from rehab medicine, those are the populations that often get compared. So what incidence are we talking about? I know my justification section is always very long for any grants because people say burn injuries. How many people even have a burn injury? So I feel like we have to justify that quite often. So we have about 486,000 patients that require, sustain burn injuries each year, with about 40,000 requiring hospitalization, and we're at about a 96% survival rate. Compared to TBI, there's 1.5 million people in the United States that have a TBI with a 97% survival rate, and then for SCI, it's about a little over 17,000 new cases of spinal cord injury a year. So that just kind of puts things in perspective a bit when we're talking about how many people this affects. I know at our burn center, and I think this is true nationwide, a lot of our care has shifted to outpatient care. We are treating patients with larger and larger burns in the outpatient setting, not only for cost, but just for mental health and convenience for patients. They'd much rather be home. So if we can build up our outpatient clinics that allow us to do larger wound cares, and better sedation and anesthesia, then that allows a patient to go home. Burn survivors are a typical trauma population in terms of demographics, where 68% are male, the mean age is 32. There are about 20% less than 5 years of age, and 75% have a burn size less than 10%. So the majority of people that we're really talking about are those with smaller burns, yet the impact can still be great. The most common etiologies really differ by age, but for the most common are fire and flame burns. But if you're less than 5 years old, then it's scald burns, which I'm sure we're all familiar with. The average length of stay is about 1 day hospitalization per % burn injury, but this length of stay increases if there's an inhalation injury or infection. And like I just mentioned, there's been a large shift from inpatient to outpatient care. So switching now to what theoretical models that we're going to be talking about, I kind of structured this because we're all familiar with Maslow's hierarchy of needs. And we can't really get to our pinnacle, our self-actualization, unless our basic needs of breathing, food, water, and sleep are met. And the same is going to be true then for burn care. So our base is the medical model. And we can't really get up to the resiliency model until we ensure that we've got survival figured out and that we are focusing on survival. So then I'm just going to go up through these different models and talk about some of the key research findings within each model. So we started with the medical model, where we needed to focus on survival and resuscitation, infection control, nutrition became a big part, and then, of course, wound healing. The psychological focus within the medical model is on pain management. And I am going to spend a fair amount of time talking today about pain. Not only is it my area of interest, but it is pretty much the key focus of burn patients as well, is their pain control. This slide just shows that severe burn trauma impacts every system of the body. And that's why this multidisciplinary care we're going to be talking to is incredibly important. But every system of the body is impacted when you have a large burn. So let's talk about burn pain. So most patients will tell us that the wound debridement that they have to go through is more painful than the initial burn injury itself. And the opiates can only take the edge off, and we need to be supplementing with non-pharmacological techniques and non-opioid medications as well. And one of the things that we learned early on when we were doing the research in the 90s is the importance of anxiolytics in treating procedural burn pain. That we all know that anxiety can really drive up pain scores and pain experience. So in the 80s, we started to see the groundbreaking research showing alarming underuse of opioid analgesics in burn care. That was driven by irrational fears and misconceptions regarding addiction. And Perry pointed this out and used the burn sample to emphasize his point of the tragedy of needless pain and the under-medication for pain on burn units. And that the tragedy of needless pain is a great article that was published in Scientific American in 1990, if you can get your hands on it. But it really did kind of drive this idea now that we've got to focus on pain. So there's different types of burn pain, and it's important to recognize this because each type of pain is going to be managed differently. So you have your background pain. So it's that pain that's always there. Then you've got your post-op pain, where there's the spike in pain following grafting that then subsides. The procedural pain, it's the one we struggle with a lot. That is the pain during wound care that spikes during wound care, and then stays high a little bit after and doesn't really return to baseline for a while. And then you've got your breakthrough pain, and that's the pain that spikes throughout the 24 hours. And this diagram just shows the importance of all these different modalities in treating burn pain. It's got to be a multimodal approach. And I'm going to highlight a few of them as to where we've come and where we are now with looking at different modalities. So one over here on the right, the purple, is just the nature of dressing changes. We are using dressings now that are multi-day dressings that can stay on, for 7 to 10 days. That's an incredible advancement. When I started years ago on a burn unit, patients would undergo debridement twice a day if they were in the ICU. That is an incredible amount of pain twice a day. And now we've come to the point, if we can put on a multi-day dressing that stays on for 7 days, it's going to allow people to go home in some cases, and to avoid frequent wound care. We're also doing, we call them AAPs, the anesthesia-assisted procedures. We've gotten pretty creative in figuring out how to do anesthesia, even on the acute floors, with our nurse anesthetists coming up and doing a lot of our larger burn care under anesthesia. Now you can imagine the battles in the hospital that went on about how to get this going, but I can tell you the impact it's made on quality of life for our patients has been dramatic. Granted, our slots are limited. I think we have about 3 a day, where we can do 3 AAPs a day on the floor, on our acute care floor. But we also had to, as you know, add monitoring to the floor. So it was an investment, but it's made a big difference. Certainly, we still use opioids. We still push for anxiolytics, but now you guys are right in the midst of this battle as well. Despite all the research we did in the 90s that showed the importance of combining the anxiolytic with an opiate to manage burn pain, we're seeing a decreased use of like Ativan and Versed because now of the focus and emphasis on managing delirium. Also important, but your anxiolytics are going to increase your delirium. So we are really in this conundrum, which you're all very familiar about. We know that there's harmful things that can occur if burn pain goes untreated or undertreated, but we also know the dangers of delirium that goes untreated. And so it's that constant adjustment and walking that line between managing delirium and managing pain and anxiety. So then your non-pharmacological techniques become even more important, your psychological interventions. We're using a lot more apps. We've done a lot of research in VR, which I'll talk about in a minute, or augmented reality. But we're also then looking at non-opioid medications, so the non-steroidals, gabapentin, and TTX, which is a pufferfish toxin that I wanted to just mention because we've started this trial, and I know our surgeons are very excited about it. But the pufferfish toxin serves as a long-acting nerve block that's supposed to be safer than opioids, and it blocks sodium channels that conduct pain messages, and you can administer it and the effects last up to 2 weeks. And so far our patients seem to really like it. They do feel it helps. It hasn't obviously completely replaced opioids, but it's something that we're going to continue to look at. I'm always surprised at, I wonder who came up with this. I wonder who figured this out. But it's a promising alternative. This is just an example of a multi-day dressing. It combines silver AG in a dressing that has broad spectrum for MRSA. Like I said, it can last up to 7 days, and we use it on second-degree burns or donor sites. I'm going to show a picture. I'll just give a little warning. This is a picture of a young child with this dressing on, so just kind of fair warning if you want to look away if you're not used to these pictures. But you can see the top there. This child has the scald burn. They put the multi-day dressing on it, and the lower picture there is what it looked like 7 days later. So this allowed the child to go home, to not have painful dressing changes every day, and the child had quite a good outcome. We also, again, within the medical model, look at non-pharmacological approaches. We did a lot of research on hypnosis and virtual reality, and what those findings showed with was that those with the highest pain levels really had the most benefit. You know, hypnosis still has a stigma even now, and in order to fight that stigma, you really have to be working with a patient that kind of feels like, okay, I'll try anything at this point, even hypnosis, but when they do, it works beautifully. It does not replace opiates, but we showed that it can decrease the amount of opioids needed. Again, the importance of treating anxiety as well as pain, even non-pharmacological management of anxiety is important. Okay, this is our virtual reality program. It was called Snow World, and when we created it, we were trying to think, okay, what's the opposite of burn, fire? Snow. Cool. So you got Snow World. So you can see, if you can see there in the picture, it's a monstrosity of a system. It's got cords and tubes and everything coming out of it with this big headset, and you go into this virtual world and you can kind of see the very primitive graphics there we had 20 years ago, and you kind of ski down this mountain and you throw snowballs at these snowmen that pop up, and it was really effective for distraction during wound care. And because we got to the point where we were able to work with engineering to do a water-friendly version of VR, which is very important, by the way. If you're going to use a VR system in wound care, you want it to be water-friendly. And it worked, but this was a $20,000 system. The only way we were able to do it is by research grants and research funding. Not practical at all. So then what do? We would give the program away to burn centers for free, but then they would have to invest in these big systems, and it just was not practical at all. Nowadays, this one might look familiar to you. I don't know if you use the Starlight system, but they're very portable. Starlight donated a bunch of these, mostly to pediatric burn centers. I think they're having some issues now because they're trying to update, and so ours isn't working until they get this new program updated. But it's a lot more practical. We've even gotten to the point of just using those cardboard goggles. If a patient has their own smartphone, you can stick it in those cardboard goggles with preloaded programs, and it can work. But we also learned about there's some definite, not problems, but it's limited. The efficacy of virtual reality is limited. One of the places where we did have some success is this, what we call virtual reality induced hypnosis. So one of the complaints that we usually got from our surgeons is there wasn't enough of us to go around to be doing hypnosis in everyone's wound care. Well, what do? So let's create a virtual reality program that induces hypnosis where you don't actually need the clinician to be there all the time. And that was pretty successful. We were able to do this program where we could induce hypnosis through virtual reality. But what are some of the other lessons learned? Virtual reality works really well for avoidant copers, but doesn't work so well for approach copers. And we learned you really need to match a coping style with the intervention. What I mean by that is this is kind of a graphic of a continuum of coping and coping styles, which on the left, you've got your avoidant copers, and on your right, you have your approach copers. And I always, like, how do you assess coping style? You can, in a research setting, you can do all kinds of things related to, you know, observational assessment or paper pencil test. We don't have time to do any of that. So I usually just ask, if it's a child, I ask the parent, when your child goes in for immunizations, do they hide in the corner or bury their head in your chest, or do they like to see what's going on and point to where they want the shot to go? I like doing this with medical providers too. Think about yourselves when you go to the dentist. Are you the kind of person that likes to have spa dentistry where you get the eye mask, you get the headphones, you close your eyes, you say, let me know when you're done? Or does that induce a lot of anxiety and you're the kind of patient that wants to know every single thing that the dentist is doing to make sure they're doing it correctly? Show of hands. Who's an avoidant coper? Give me the spa dentistry. And who's the approach coper? Yeah, exactly. So for those of you on Zoom, typical of most healthcare providers, we are all approach copers because we want to make sure people are doing it right. But you can kind of see then the coping style matches some of the different non-pharmacological interventions that we have. Virtual reality, hypnosis definitely fall in the avoidant coping continuum there, or the avoidant side. You can find this out right away if you stick an approach coper in a virtual reality system. What are they going to do? They're going to rip the helmet off and say, nope, this is not for me. And that's fine. You're not doing damage. You just pick a different technique. But they'll pretty much tell you right away. What happens if you go in and you're giving a lot of medical information and procedural information to somebody who is an avoidant coper? You're going to notice they're starting to get anxious. They don't want all this information. They might say something like, you know what, doc, I trust you. I don't need to know this. Just do your thing. And so patients are pretty good about telling you what they need. The other lessons we learned from VR that is length of stay shortens. So again, we're transitioning a lot of our care to the outpatient care. We really have less time that VR is useful because by the time delirium clears, patients move to the acute floor and they need to start learning their own wound care to go home. They can't be in a virtual reality system when they need to learn their own wound care. And again, like I said earlier, a lot of our care is shifting to the outpatient setting. So, and you can't use VR with someone who's delirious. So it is a bit limited there. We're also having some empirical debates. For example, the longer someone uses an avoidant coping style like VR, does this actually increase the length of stay? Because they're not actually learning to cope with these painful procedures. Don't know the answer to that yet. And I know in my own burn center, I get a lot of pressure to move people along the coping continuum from approach to avoidance to get them out sooner. This includes parents. If you have parents of kids who are hesitant to do wound care, it's too hard to look at. I like to support whatever coping style they're at in the moment. But at some point, we got to move them on that and I use gradual exposure to move them along that continuum to get to the point where they can take their child home to do their own wound care. We also learned that VR works well in an outpatient setting, both with adults and kids who want to be distracted for a painful procedure. I know a lot of our surgeons use Kenalog injections into scars. That can be pretty painful. We can stick a VR helmet on them while they do that. That's tend to work well. But the system has to be small and easy to use and include a choice of programs from interactive games that the kids usually like to relaxation or documentaries that the adults tend to like. So it's usually patient's choice, which is what's most effective. There's also more interactive programs. This is the augmented virtual reality that is effective as well. So that's kind of what we learned from the medical model. Now, moving up here a bit to the psychopathology model, I'll spend a little bit of time here. What we were finding out is the more people survived, then we needed to start looking at rates of pathology. The development of large databases allowed us to gather this information, and we were able to finally look at rates of depression and PTSD and found that they are in fact higher than the general population. No surprise there. But the rates really vary across studies. Even now, this current data was pulled from 2025 publication, and the rates for depression varied from 13 to 23% at 1 year, maybe a little lower than you were expecting. But then 2 years is all over the board at 27 to 45%. And that's a lot. There's a lot of reasons for this. It's at what point do they assess and what tools are being used, and are they actually looking at diagnosis or just symptomatology? There's a lot of problems that we're trying to figure out in how to accurately get at some of these outcomes. There's also been a lot of risk factors that have been identified, and these really vary between modifiable risk factors and fixed risk factors. There has been a little bit better research done on suicidality after burns. The suicide rates are about 5 times higher in the burn population than the general population. And one of the key findings, that high acute pain levels at discharge is a predictor of suicidality. And so just as we need to worry about delirium and we need to worry about addiction, we also need to worry about what is the damage of untreated high acute pain. I will say too, this is a bit of a commentary, burn centers did not cause the opioid epidemic. We are very, very good across the nation at getting people, weaning people off their opioids when they don't need them anymore. It's very well supervised, very carefully done, and I believe nationwide our rates are, it's like 98% of people are weaned off their opioids by 3 months after a burn or after wound closure, depending on when you track. Those that are still on opioids are those that were on them already. So they came in with a burn, already on methadone maintenance, or already had an addiction to opioids. That is a problem that we need to figure out. But in general, people are not becoming addicted to opioids because they got a burn injury and we just never weaned them off. We're really good at making sure that doesn't happen. What about outcomes of acute stress disorder and PTSD? This is another challenge. Over 90% report at least one symptom of acute stress. Pretty reasonable, right? It's expected. And then the rates of PTSD at 1 year really range from 15 to 45%. And some of the risk factors for PTSD vary, but include symptoms of acute stress in the hospital, prior history of trauma, and female sex. I know in talking to Dr. Matithil about this, we've all had the same experience where we get a lot of patients with symptoms of acute stress or PTSD, but not many that actually meet diagnostic criteria to give them a diagnosis, which makes all of this research really complicated. But the bottom line is a lot of these symptoms are distressing enough that you still got to just at least treat the symptoms. Why is this important to look at? As you probably know already, those with psychiatric disorders have longer lengths of stay. They typically require more surgeries. They have higher rates of infection, and they're less likely to participate in care or adhere to treatment recommendations. So we do need to address this, as well as just better quality of life. So finally, in 2019, the American Burn Association mandated screening for psychological issues, and this was a big fight and a big win that we got this, and they mandated it for those who are going to be verified burn centers, that we need to screen for depression and suicidal ideation, PTSD, and substance abuse. And now I think there's various models of how this is done. I know your model differs than ours, but they at least leave it up to the burn centers to figure out how to meet this requirement. So the biggest finding then in this model is that a large burn does not equal bad outcomes necessarily, that we can't use TBSA as the sole predictor of depression, anxiety, PTSD, or low quality of life. We have all now seen examples of people with very large burns do really well, and that's so motivating, I think, to most of us to see. It's a great story. But we also see people with very small burns not do well at all. So we can't use TBSA as our screening or as the predictor for psychological outcomes. So the biopsychosocial model, y'all have taught me about this. This came right here from Dr. Engel at the University of Rochester. This is exciting. I was excited about this model when we started adopting it, where we finally got to look at premorbid risk factors, whether it's mental health, alcohol and drug use, and various social determinants of health, combined with the injury factors, inhalation injury, TBSA, length of stay, rate of delirium. We found that those can be mediated by social support, so strong social support, as well as coping style, like I mentioned earlier, on outcomes like depression, anxiety, PTSD, and return to work or school and a good quality of life. So one study that looked at this, we had 231 people, we followed them for 2 years, and found that pre-burn emotional health predicted better adjustment and was related to less use of avoidant coping strategies, and that less use of avoidant coping strategies was a mediator between pre-burn mental health and development of PTSD. But the question then becomes, well, where do we intervene? And can a person really be taught a more adaptive coping style in the context of a major trauma? If you've ever tried to do that, that's really hard when they're in the ICU or even the acute care, to try to teach them a different coping style. But what it did point out too is really the importance of a multidisciplinary team. Both psychiatry and psychology are very important. There's different models and different ways to incorporate psychology and psychiatry into burn care. There's kind of a consult service model versus embedded in a team. And I know at University of Washington, we have a very similar model as yours. So like Dr. Mathill, I am embedded in the burn team, but we have a very robust psychiatry consult service that we rely on considerably, and we work really well and really closely together. I think it's also important just to acknowledge that all levels of training have a role in providing mental health support for burn survivors, whether it's a bachelor's level child life specialist, a master's level counselor, a PhD level psychologist, or an MD psychiatrist. We all have a role, and all of those are really important. I came up with this chart, and actually it was after a discussion that we had earlier this week about how psychiatry and psychology sort of share the workload at our institution. Again, it's different at other institutions. But I will say the first one on here is the screening piece. So I mentioned that, you know, we're mandated for screening now. This is aspirational for us. In my ideal world, if I were designing things, I want a behavioral tech to do our screening. So somebody that can screen everything for burn verification, for trauma designation, for pediatric trauma designation, can do all the screening, and then can triage what this person needs. Do they need psychology? Do they need psychiatry? Do they need spiritual care? Do they need social work? And get them to the right places. And a behavioral tech is also trained where the screening becomes an intervention, per se. They have that training and that those skills. I think it would be ideal. I'm still trying to sell the hospital on that. They haven't bought it yet. You know, we want to work at the highest level of licensure, right? And having your MDs and PhDs do your screening probably isn't the best financial model. I don't know how to convince people of that, but I'm still working on it. For medication management, that always falls to psychiatry for us. Behavioral restraints and safety, especially after self-immolation, that always goes to psychiatry. Treating severe mental illness goes to psychiatry. Assessing decisional capacity, we share that. And so if the reason that somebody might be impaired is from a psychiatric issue or a mental health issue, then psychiatry takes it. If it's from a medical issue like stroke, TBI, polytrauma, delirium, then psychology does it. Kind of maybe an arbitrary, but that's what we decided. Non-pharmacological management of ASD, PTSD, and mood go to psychology, but we often consult psychiatry for medication recommendations. Adjustment to injury then falls to psychology. Body image concerns go to psychology. And then family support we share between psychology and like our child life specialists and our social worker. So that's just kind of how we split it up. And I will say too that some patients get both or all three. So if a patient had a self-immolation burn, but psychiatry managed them and they're at the point where they're safe, they're no longer at risk of harm to themselves, they kind of turn it over to us to do a lot of the burn-specific care of body image or pain or reintegration into their community. Okay, so moving on then to a rehab model. I had to throw this in there because I'm from the Department of Rehab Medicine and I do feel like rehab has a really important role. And the rehab's focus tends to be on increasing functional behaviors to improve long-term health-related quality of life by helping with decreasing scarring, increasing mobility, and helping a person go back to whatever their meaningful role was in society. And our rehab medicine providers tell us all the time that good functional outcomes start in the ICU. That's where we get that early mobility, that push for early mobility. We want to decrease delirium so that they can participate in their therapies and early mobility, making sure that pain and anxiety are well managed and that acute stress symptoms are treated. So identification of PICS or post-ICU syndrome, this has kind of gotten a lot of press lately, and I gotta say, we have known about this for years. This is nothing new, right? Now it just has a name. But it is something that we need to pay attention to, and simply the recognition that no matter what the cause of somebody ending up in an ICU, prolonged stays in the ICU can have long-term impacts on mental health, whether it's anxiety, PTSD, or depression, cognitive impairments, so impairments, executive function, memory, attention, processing speed, and even physical impairments on pulmonary, neuromuscular, and physical function. There's also kind of an offshoot here that a long ICU stay has stress on the family. And the family can also go through their own period of adjustment and mental health concerns. So this is, I'm not sure how we're going to really address this or what we're doing about it. I don't feel like we need to do much differently other than we are getting rehab medicine involved more often, and we've now incorporated one of our physiatrists into our burn clinic 1 day a week. So 1 day a week, our physiatrist comes into burn clinic and only sees those patients that had a long ICU stay. And she and I work together to do some of these screenings for cognitive impairments and physical impairments, and then figure out where to go from there. And some of them are seen then in the rehab medicine outpatient clinic as well. Part of the rehab model, though, is also focusing on this long-term quality of life. And so you also are seeing with this model, push for involvement of survivors and consumers in all aspects of research. I think we even had a push through a lot of our grant funding is through NIDLR in the burn model system, and they want survivors on our publications. They want them involved in every aspect of the research. And so one of the projects we did is, well, let's ask them, where do we go from here? Will you tell us what is causing you distress? And they brainstormed 50 symptoms. We assess then pretty much anybody, 1,000 people over 8 years on this, asked them to rank your top 12 reasons for distress. And then I was interested to see, did they change over time? And what we did find is that the mean distress scores are lower at 2 years, indicating there's lower level of distress overall, and they do improve over time. But the long recovery time and financial concerns were the top reasons for distress throughout the whole 2-year period, and that surprised us. Oftentimes we forget about the big financial burden that having a major burn injury causes and the stress that causes on families. And so we kind of put more emphasis at that point then on returning someone back to work, because that's their financial livelihood. That was, we couldn't rely on insurance, so that was really our only way, is to help them get back to meaningful work. Now, we're not very successful at that if they weren't working prior to the burn, but if they were, what do we need to do to get them back there? Or to work with our vocational counselor on more job accommodations or job coaching or retraining. So we put a lot of emphasis then on our vocational programs, and that's been a real big emphasis of NIDLR then. We have a vocational counselor in our outpatient burn clinic that meets with every patient who was working prior to the injury. That's been a real help. She then gets me people sooner if PTSD is a reason that they're not returning to work, or body image. They're having a hard time with their scars. They don't want to go out in public. They don't want to return to work. So I can get involved earlier in that. Okay, so finally then we've arrived at the resiliency model. My background is performance psychology. I was a sports psychologist for a long time before this. So in sports psychology, we study the people doing well. We study the winners, those who are winning championships. And I never understood that. I come over to psychology and we're just studying the people that have issues. And so I was like, well, what about the people that are doing well? What about our burn survivors who are doing really well despite a 70% burn? And so this is a growth model instead of a deficit model. It focuses on post-traumatic growth and resiliency. We're seeing more and more studies on this now. That's exciting. We're studying characteristics of those who are doing well, even if they do have risk factors. And we're studying trajectories. meaning can we identify factors that lead to a certain trajectory of long-term recovery? One of my favorite studies that I did recently was I was able to identify, it wasn't a huge number, but at least a small number of people who were not doing well at all before the burn injury. And then 2 years later, their quality of life was better than it was before. And you think, well, what is it about them? This is great. You know, what is it, this hardiness, right, that they have, this grit, and how do we keep supporting that? And one of the things that we found was that, or in trying to hypothesize why this might be true, and they told us this, it got them into services. So having a burn and they come into this very, you know, all of you know, caring, multidisciplinary burn team, and then they get followed for years in this multidisciplinary clinic. They said they'd never gotten anything like that before. So having the burn actually brought them into getting more services. And if we can focus on that, I think that that helps kind of all of us in terms of meeting our own burnout in this work. And it helps us too that we're not in a climate where we can give all services to everyone. So how do we predict who is going to need these services and where our interventions are going to be most effective? In order to do that, we've got to intervene early. We've got to get our mental health services involved early on. This is where that trauma-informed care comes up in the promotion of a universal screening. How to screen everybody so we can identify risk factors early on, intervene early on with the people most at risk. And then the other thing that we need to do, which we hear about all the time and we try to do, but decrease the traumatic nature of the medical setting so that the medical care itself doesn't become an additional trauma. And I'm sure we've all had this experience where you see somebody, however they've been discharged, however much later, 6 months later, a year later, and they're having some PTSD symptoms, and you ask them, what is the trauma? And it's not the initial burn injury, it's the ICU stay, or it's the wound care that they got while they were with us, which again, you see my theme now. It really emphasizes the importance of adequate pain and anxiety management because painful wound cares can cause PTSD in and of itself. And adequate pain management is an important tenet of trauma-informed care. So what are the lessons learned throughout the years through all these different theoretical models? I think I've emphasized it all along, the importance of a multidisciplinary team. One specialty or discipline can't address all the needs, and we need to strive for the best long-term outcomes in all areas of a person's life. So asking them that question of what makes life worth living for you, and how do we get you back there? So anyway, thanks for having me. I appreciate it.
Thank you so much for this wonderful talk. I'm going to check to see if there are any questions online. While I do that, if anybody has questions, let us know. I'll pass the microphone.
Hi, I do have a question about your the opportunity for a behavioral technician. Is that already been applied somewhere? And if it's so, what's the behavioral health function? Are they an RN? Are they certified? How are they trained?
Yeah, great question. I was struggling with this, so I looked around and asked different medical centers. Our children's hospitals tend to use behavioral technicians. So just Seattle Children's Hospital, which is across the way from us, they have a whole team of behavioral health technicians. They're bachelor's level. Some are psychology majors, some are not, but bachelor's level that they train themselves then to do the screening and do a brief intervention depending on results of the screening. So the way I'm kind of sort of moderating that a bit is right now I am using a psychology graduate student, so from our graduate program. Now, she's got 6 years of graduate education underneath her belt. So she's fantastic. She didn't need much training, but she hadn't been in an ICU before, so I did write out a script for her of what to say. We did the injured trauma survivor screen, the ITSS, the 9-item, and she's excellent. And it's a nice pipeline, so now she loves it. She loves the burn unit, so she's going to apply for internship or residency with us. So I think providing opportunities in that way. There's no cost because she's a graduate student. She gets a good letter of recommendation and experience. I don't love using free labor. I think we should be paid for our skills. But in the meantime, that's what we've got. But bachelor's level person that trained. She reports to me. Yeah. Yeah. Now, if it was a behavioral tech, they wouldn't necessarily need to. They could report to social work. I don't know if we have our social workers here. I think there's often social work extenders that can be used in this role that are also bachelor's level with a degree, with a bachelor's level in social work, but not licensed yet, that they oversee. I've seen hospital use social work extenders. Is anybody here from social work or online?
I was just going to say,
Yeah.
On the brain injury unit in the main hospital, we have behavior techs report to the rehab psychologist.
Nice.
And so there's a version of this model in a limited fashion at our institution.
That's perfect.
Yeah.
And they're bachelor's level, they're trained by?
I'm unclear about their level of training.
Yeah. That's great.
But they fall under nursing.
Fall under nursing. Yeah, it doesn't matter. I get them in here. That's great.
Again, thank you so much. I specifically want to thank you on mentioning PTSD growth. It's a topic that we don't often mention, and that's wonderful. I have a question. How do you incorporate families in the work that you're doing, whether it's education? I mean, what do they expect?
Yeah.
This is a major injury.
Yeah.
It's changing so many aspects of a person's life. How is family involved? And my second question is about palliative care. Is there a palliative care component to your work?
Great questions. And I didn't talk as much about family. We do a lot of work with family. I do a lot of work with families as well as our social worker. Honestly, the majority of my work in the ICU, especially if the person is still intubated and sedated, is to work with the family that's there. Our burn center is unique in that our catchment area is the 4 surrounding states. So people are coming from Alaska, Montana, Idaho. They're staying for months at a time. They're being displaced. Some of them have other kids at home or family at home, and they need a lot of support. It's hard. It can be hard. I get challenged on this a lot because I can't bill for my work with families. But if I can show that it's taking some of the burden off of nursing because they're so busy at the bedside, they don't have the time to help support families, and that by supporting families and moving them along this continuum, I can get patients out faster because the families will be ready to take them home. You can kind of justify it that way. But the family is an incredibly important piece of this. We do have palliative care. We use them. I think more and more we're finding we need to educate our palliative care providers that people with large burns can have a good quality of life. I don't think that that's a message that they often hear, and if they're the ones that are going to be counseling families of what to do, we need to make sure that they have that information of what kind of quality of life a person can achieve with a large burn. Yeah.
Okay, well, thank you again. Thanks so much.
Well, and I wanted to thank you too. The last thing I want to say, part of my role with the well-being and retention is I see the burnout on burn units. What you're doing is hard work. And whatever we can do to support you all in doing this emotional work, I think is important. What some of our nurses and therapists will do is they'll come to the outpatient clinic just to see how well this patient is doing, especially our ICU nurses, taking care of a 70% burn months on end, they don't often get to see that. And so we invite our ICU nurses into clinic to see patients and how well they're doing. We also invite them out to burn camp to see how well the kids are doing after caring for so long. They've said that that can help decrease burnout and moral distress. So we need to look at these resiliency and retention programs because what you're doing is so very important. We want to keep you in burns. So thanks for what you all are doing.
Thanks again.